Level 2 vena cava thrombectomy and robot-assisted radical nephrectomy following immunotherapy. Our patient is a 69-year-old man without previous medical history. A CT scan performed in the context of anemia revealed a large white renal lesion with extension to the renal vein and the vena cava. Extension workup showed retroperitoneal lymph node invasion and pulmonary metastasis. Final diagnosis was poor prognosis clear cell renal cell carcinoma with synchronous lymph node and a lung metastasis. A combination of nivolumab and ipilimumab was initiated. After 4 cycles of treatment followed by maintenance nivolumab, a good response was observed on metastatic sites with stability of the renal mass and partial response on vena cava thrombosis. Surgical management was then validated with robot-assisted cytoreduction nephrectomy, vena cava thrombectomy and retroperitoneal lymph node dissection. As seen on this scan, the partial response of the thrombus corresponds to a retraction and a shrinking rather than a decrease in its level. After colonic detachment to locate the psoas plane, the ureter and the genital vein, the anterior and the lateral sides of the vena cava are dissected and released. Intraoperative ultrasound is then performed to visualize the thrombus extension. Dissection is extended to the posterior face of the vena cava, where the lumbar veins are progressively clipped and sectioned. The right lateral side of the aorta is then released to perform the inter-aortic caval lymph node dissection and then isolate, clamp and section the right renal artery. A vessel loop is placed over the left renal vein, the subrenal vena cava, and the subhepatic vena cava. A 4-0 proline is tied below the rostrum of the renal vein before clamping the subrenal vena cava, renal vein, and subhepatic vena cava. Absence of venous flow is confirmed by sectioning the genital vein, over which a hemolock is then placed. Cavotomy and thrombectomy are performed as a single block. The thrombus is thin, retractile, and highly indurated. Vena cava is then sutured using a 4-0 proline. Before complete sealing, abundant irrigation of the vena cava is performed and the left renal vein is unclamped in order to obtain blood backflow. Clamps are removed from the vena cava, and finally lymph node dissection and nephrectomy are completed and extracted in one piece. The procedure lasted for 3.5 hours with 15 minutes of vena cava clamping. Blood loss was estimated at 200 cc, and postoperatively a pneumothorax related to the central line placement was drained. The patient was discharged at day 7 without further complication. Final pathology report concluded to ISUP-free clear cell renal cell carcinoma with carcinomatous thrombus. Extensive fibrous and necrotic changes were probably related to immunotherapy. The removed lymph nodes were free of metastasis. At 6 months post-op, the patient is still receiving maintenance nivolumab and is in very good general condition with no abnormality on blood tests and no sign of local or distant relapse on imaging. This multicentric French retrospective study included 44 metastatic patients with venous thrombus and treated with immune checkpoint inhibitors. It showed a response to immunotherapy of about 36%, but mostly on diameter and without change in thrombus level, which is consistent with our case. Finally, the impact of immunotherapy on surgical difficulties is debated. In this case, surgery was feasible with no more difficulties than without immunotherapy.